them on their side, you got to protect their ankles. You got to put another pillow between them to keep their knees from bunking together or keep their knees off of the bed. You're going to put a pillow behind the back to keep them from falling back over, or if we're using the Prevlon turn in position unit, then you use that instead. And then don't forget about a pillow underneath the head. So that's the 5-pillow rule, best practice. Here's a really simple way for you guys to determine if you need to float that patient's heel. On your assessment, ask them to show you if they can lift their leg and hold it up in the air for a few seconds. If they can't, you have to float their heel. The rule of 30. So that means that when they're lying on their back, you should not have the head of the bed elevated beyond 30 degrees, because that's that shear factor we talked about, right? You got them up, you've got gravity, you've got friction, skin stays, body moves, and you're going to break down the bottom. So put the head of the bed up to eat. If they need to be up for a brief period of time to talk or to visit, you want to get that head of the bed flat, because how quickly can you develop tissue ischemia?
30 minutes.
Right, okay, so you need to be thinking about that. Also, when you put them on their side, you want to think of the rule, the 30-degree rule, because you don't want to place them over their shoulders and their throat, so you just want to rotate them 30 degrees off of supine using positioners to help them stay in that 30-degree lateral inclined position. So some more stuff, obviously, you want to be using draw streets and trapezes so that you're reducing the friction in the shear. Don't, if possible, position them over the area breakdown. If you have a decube on the bottom and you got to get the patient up to sit, they really should be in a specialty pressure device or pressure relieving device like a ROHO. The physical therapy, occupational therapy department here keeps those because they're like $800. So we just need to make sure we get them up there and we get them fitted appropriately, and then God, I hope they don't walk out with the patient, that we get them there only by the time they leave. Never massage reddened areas. That basically is friction. So you might think, oh, if I massage it, I'm going to bring blood to the area and I'm going to help it heal faster. You're doing the exact opposite. You're causing physical, mechanical trauma and friction to the area, and you're going to make it worse, not better. And then keep in mind, those heel pads and elbow pads that we have, those are not designed to relieve pressure. Those are only designed to relieve friction. So they're good, but they're not going to prevent pressure. So don't put a heel pad on a person and think they're not going to get a pressure sore on their heel. So I talked about a lot of those. I talked about moisturizers and why that's so important. Hydrating from the inside, because obviously they're not making enough moisture. They need, and I'll go over it, at least 1,500 cc's of fluid a day. Transparent dressings, that's a great thing to put over high friction areas, or high friction areas, elbows, knees. If they got, their spine sticks out, things that just toughen up the skin, kind of think of a callus. You're just adding something to make the skin tougher so it's not as likely to friction off. Same thing with skin sealants. So when the person is sitting, first of all, if they're at risk, you need to instruct them that they need to reposition every 15 minutes. If they can't do that, then you need to get them on a pressure cushion, and you need to make sure you or somebody is manually repositioning that person every hour. So we ordered a bunch of pressure distributing devices. They seem to have all disappeared. We're going to order some more. It's a pretty simple one. The top layer of it, top part, one half of it is designed for people 150 pounds and less. If you flip it over the other way, it's designed for people 150 pounds or more. Because, obviously if you put a light person on something designed for heavy, you're creating pressure. Vice versa, the person's going to bottom out. And so we're going to order more, and then we're going to have to engage you guys to find out how can we standardize this so it's not staying in the wheelchair as the patient's going to the nursing home and that becomes theirs forever. So we'll be ordering more of these, and we'll figure out how to keep them around. Make sure you're checking your heavier patients for bottoming out, because if you're bottoming out, it's not doing any good. Does everybody know what bottoming out means? So shear, we talked about all of this, lift sheets, head of bed, turn in position, pillows, wedges to basically keep them put. When they're sitting in wheelchairs primarily, be aware of the hammock effect. How many of you have been on a swing lately, the little black rubber swings? Anybody?
Been a couple years.
Been a couple years, but
yeah.
What happens? You sit in, they roll up behind you, your legs roll in. That's the hammock effect, okay? It's the same thing putting somebody on a pillow for pressure relief. The pillow comes up around them, creates the hammock effect, rolls your legs in, puts pressure on your greater trochanters, causes your body to slouch. Then all of a sudden, your spine and your ischium and everything has shear, and so now you've created a whole other problem. You can't fix that, by the way, by sticking one of our pressure cushions underneath there. The seat's bad. It needs a new seat, and that's the only way you're going to fix it. So get them out of that chair, take it out of distribution, call engineering, have them get a new seat, or whatever. I'm not going to spend a lot of time talking about specialty beds and support surfaces because I know there's a Hillrom rep upstairs. But they, kind of go in 3 different levels depending on the risk and acuity of the patient. And you need to make sure you're aware of what those are, what beds you can get, how you order them, etc. Incontinence, again, you guys are the experts on this. I'm just going to touch base on it kind of quickly. Retraining the bowel and bladder. Sometimes I think we forget that in an acute care setting, and we assume that's going to happen in the nursing home, or we assume that'll happen in home health, they're at home. But if it can start here, it's better. I mean, obviously, the sooner we get that patient continent, the better off they're going to be. For loose stools, think about the cause. Is it C. diff? Is it yeast? Is it something we can treat? If it's not, is it something we should get a dietary consult for and see if we can add some fiber in? Can we bulk up their stools? When you clean them, you don't want to use hot water. Hot water is going to strip any natural oils they have on their skin off of it, making it more susceptible for breakdown. You don't want to scrub to get the stool off. Make sure you're using one of our sprays that we have that actually has a surfactant in it that's going to loosen the binding of the skin and the stool on the skin, or the blood, or whatever might be on the skin. Make sure you're using a skin barrier every single time. Make sure you have them available in the room. The biggest problem I see is you go in to clean the patient, you get them cleaned up, you want to skin prep them, and it's not there, so you leave the room to go get it, you get called away, and the next time you remember is when you go back in to clean their skin up. And so you'll go many, many times of treating their incontinence before you actually skin prep them, so try to keep that in mind. And then, I know we do this here, but make sure that you're only keeping those briefs on those patients when they're up in a chair or up walking. You really want to keep them open when they're in bed because of the sweating. Remember, sweating decreases the acid mantle of the skin, making it more prone for breakdown. So you've done everything right, and they still have a pressure ulcer, or they come in the hospital with a pressure ulcer. What should you do to treat it? So first of all, do your full assessment, find out everything that might be contributing to that, and remove every single cause as much as within your control. Keep in mind, the stage 1, do everything right, it can be gone in a day. Hydrocolloids, there's been some research that has been done that not only are they a good dressing to use, but they may be a superior dressing to use in increasing the healing rate of stage 2s and stage 3s. There's a little bit, they're starting to do some research on are they good on stage 1s as well. And they're thinking that yes, they are, but only if they're transparent and you can see through them. At St. James, I've never seen us have a transparent hydrocolloid. I've never even seen a transparent hydrocolloid. I don't know if they exist or not, but it's just, that was new to me that I actually just found out when I was doing the research for this. In the stage 1s, it's probably a better idea until I find out if such a thing exists, just to use a clear film to protect it. If it's a heavily exudating, lots of drainage on a stage 2 or a stage 3, or if it's a stage 4, you got to start thinking about some other types of dressings. Foams, alginates, composite dressings, those sorts of things that will handle that moisture a little bit better and maintain that moist but not macerated environment. As they get really bad, that's when your specialty team's going to come into play, and you're going to start thinking about specialty wound care stuff like wound vacs, extracellular matrices, skin grafts, etc. Non-sterile dressing change technique. I'm going to go over this again. You can refer to the policy, policy VA76 on the communicator. But basically, we need to be changing our gloves a whole lot more than we typically change our gloves when we're doing a dressing change. So I'm going to start with this analogy. If you go to Subway, and any restaurant, and you pay, the person has gloves on. You hand them their money, they take your money with their gloves on, they handle the cash register, they stick it back in, they hand you your change, keep the same gloves on and go over and start making your sandwich. Are you going to be very happy? So why do we do that when we're doing dressing changes? Same exact concept. So what I see happen a lot is you put one pair of gloves on when you walk in, not you, people, healthcare providers, so they don't think. You put one pair of gloves on. You open the dressings, which could be contaminated on the outside, right? Somebody could sneeze, have staph on them, whatever. You open the dressings. You go to the patient. You reposition them. Could have stool on the bed or whatever. You reposition them. You take the dressing off, which is definitely going to be contaminated. You throw it away. You clean the wound with your dirty gloves that already have contamination. Now you go grab the clean dressings that aren't clean anymore because your gloves are contaminated. You slap them back on. Basically, all you did is you just kind of you reapplied the same contaminants right to the wound bed, right? Same exact concept of somebody handling your food. Think of everything your gloves come into contact with. If it's come into contact with something clean, would you put your gloves in your mouth? If you wouldn't, don't stick it back on the patient. So walk in, clean your hands, open the dressings. Clean your hands again because they're dirty. Put on another pair of gloves. Remove the dressing from the patient. Clean the wound. Take off your gloves. Clean your hands. Put on a new pair of gloves. Take a clean dressing. Put it on the patient because you don't want to be causing cross-contamination or recontamination. This is another big one, and sometimes it's our providers that can be the worst because they'll order these things, and we just have to make sure that we know what to tell them. So the Agency for Healthcare recommendations. If somebody has a pressure ulcer on their occiput, I haven't seen this in a while. I'm curious if you guys have. Somebody will say, oh, we'll order a donut. Or they got a sacral pressure ulcer, go up to OB and get one of the donuts and have them sit on that. That is contraindicated. It's actually going to make it worse. And can anybody tell me why? Exactly. Yeah, exactly. Because when they sit on that donut, yeah, you're floating the area underneath it, but you're causing a very discrete area of pressure in an area that already is ischemic. So you're kind of pressuring off any blood flow that could be getting to that area. So don't use foam cutouts, donuts, etc. Probably about the worst thing you could do. Probably better to just keep them on the mattress than use that. So nutrition. Nutrition is important, and I don't know how much you guys pay attention to the labs, but I find it interesting, so I thought I'd spend a little bit of time going over it. Obviously, it's always a good idea, any wound care patient, anybody at high risk, get a dietary consult. They're the experts, have them work with the doc. But here are some labs that are recommended for different kind of ulcers, because it's going to tell you a little bit about their ability to heal. So for pressure ulcers, which is what we're talking about today, you should look at an A1C, an albumin, that's debatable, I'll talk about that in a second, glucose, hematocrit, hemoglobin, and a prealbumin. Some of them, the other ones, and some of the other labs are going to be important. What do each of those tell you? And I'll just go over it sort of quickly. Your albumin is kind of a long-term measure of how much protein a person has in their body. Looking at 18 to 21 days, meaning you're not going to see a change in their albumin level for 18 to 21 days. So in an acute care setting, not a great way to measure their protein stores. Prealbumin is a little bit better way to measure. It's a more, it will show us change in 1 to 3 days if you increase their protein. Transferrin is a really good way of looking at protein stores. Transferrin transports iron to the bone marrow, and it measures how much visceral protein you have. It actually responds a lot more faster than albumin, and just shows a different measure than prealbumin. Total lymphocyte count, basically it measures the immunity to proteins. Your TLCs are required to elicit an immune response for healing. So if you have a deficit there, your healing response is going to be reduced. Glucose, that's important because it impairs healing by impairing the ability for lymphocytes to do their job, and then that whole immune response to get in and start to heal a wound. Hematocrit, basically it's a low red blood cells. You have decreased oxygen carrying capacity. If you don't have oxygen, you can't heal. And then a CBC is a blood count that just kind of gives a general overview of the total health of the patient. So markers of malnutrition, because that's a big, if you're malnourished, you're not going to heal. Period, end of story. So some markers that you can look at is body weight. So if a person has had a 5% weight loss in a month, or a 10% weight loss, unintended weight loss in 6 months, they are malnourished, they don't have enough protein, they don't have the ability to heal. And here's just another way of saying that, mild, moderate, or severe weight loss. And the reason for that is because the protein isn't necessary, the nutrients aren't necessary to heal that wound, because it's not even necessary to maintain life. Albumin, and again I have a star on that, I'll talk about that in a bit. Pre-albumin, you know, anything less than 16 is considered at risk for not healing. Transferrin, anything, less than 200 is at risk, and total lymphocyte less than 1500 or greater. I thought this was really interesting, something to consider, just a little blurb. Sick people don't produce as much transferrin as a healthy person. So their iron is going to be lower, right? Because transferrin transports iron to the bone marrow. But if you make the mistake and say this person's low on iron and you start supplementing with a whole bunch of iron, that iron can't be absorbed because it doesn't have the transferrin to transport it to the bone marrow. And in the body, it changes into ferritin, which then is related to higher infection rate. I just thought that was a really interesting thing that I didn't know before. So why is albumin maybe not a great marker of malnutrition, or particularly of protein? And there's a whole bunch of studies. This is just one of them. Back in 1944, they did a study, and they actually had people volunteer for this, where they starved them in Minnesota. And then they did lab tests on them and see what their lab did. Well, these people were like close to death. They had like 1–2% body fat. They looked like concentration camp victims. You know what? Their albumin was completely normal. So it tells us that, is albumin really a good marker for us to be looking at to see what their protein stores are? And it's probably not. Not that we shouldn't do it, but don't only do an albumin. Make sure you're looking at transferrin or pre-albumin. So unintended weight loss, I talked about that, right? But I want to talk about why you won't heal. So protein is necessary just for energy formation, right? If you don't have enough, if you're not eating enough protein, your body needs to get that protein somewhere, so it steals it from your muscle. If it's stealing it from your muscle to keep you alive, how can it possibly donate the protein necessary to heal a wound? It can't. So you're going to enter into this catabolic state where your body's eating itself and it's not healing, and you're going to have a chronic non-healing wound. So that's why protein is so important. So what are the nutritional needs? Again, you don't have to be the expert on this. Get a dietary consult, but this is just kind of interesting information. Your calorie needs go up to about 2 times if you don't have a wound pressure ulcer. Your protein needs go up from about 1.2 to 1.5 grams per kilogram of body weight. That equates to about 4 good protein sources a day for most people, depending on how big you are. You got to have fats to develop cell membranes. You got to have at least 15 milliliters of fluid, depending on how big you are. Arginine and glutamine are amino acids responsible for collagen formation, and it can't be metabolized when you're sick or stressed, so you got to supplement them. Vitamin A, B's, and C's are all necessary to heal wounds for collagen and amino acids, all of that. Without them, you're not going to heal. Copper. You got to have copper because that requires that's what enables your collagen to link together to form nice stable scar tissue. So if you have weak scars, or if you have a patient who heals and opens and heals and opens, think about, are they getting enough copper? Chances are they're probably not. And then iron is obviously necessary. Keep in mind, if you have those dehiscing wounds or that weak scar tissue and you're thinking, copper. Well, copper, zinc, and iron all compete for the same cellular receptor. So if you have a patient who's supplementing with zinc because they heard it's good for them, and they're supplementing with more than 30 milligrams, they're probably binding up that whole cellular receptor, and there's nowhere for that copper to even go. And so maybe they need to back off of their zinc for a little bit so that they can bind that copper and have nice solid scar tissue. Another study came out that shows there's absolutely no benefit from supplemental vitamin C. So if you're getting vitamin C in your diet, they haven't found any benefit in supplementing, and in fact, it's been had harmful effects on patients with kidney stones. I talked about arginine, the different amino acids. So another concept to consider when you're giving dietary advice to your patients is there's things called complete amino acids or complete proteins and incomplete. And obviously to heal, you need all those amino acids, so you want a complete protein source. Those are typically your pure protein sources like steak, chicken. When you start getting into protein sources like hamburger and lunch meat, they may or may not be complete because if they have fillers in them, and a lot of hamburgers and most lunch meats have fillers in them, they don't have all the amino acids and they're not getting it complete. So if your patient is eating their protein by having hamburgers all day long and they're not healing, maybe it's because they're not getting a complete protein. And then tofu, believe it or not, is a complete protein source. So for those vegetarians, that's good to know. Here's another little thing. Protein is most important to have at breakfast. If you are in a protein deficit or you have a patient in a protein deficit, their prealbumin is low, and you wait, they have pancakes and toast for breakfast, and they have, who knows, carbs for lunch, and then they have this big old steak for dinner. Unfortunately, they've been catabolizing their body all day, stealing protein all day, and then overnight, that protein that they ate is doing nothing more than replacing the protein that they stole from their body. You have to have protein available early in the day, not only to prevent catabolism, but then to hopefully donate to wound healing. Encourage blood flow. You heal through blood flow. So everything else is great, but now you got to get blood flowing. When you're sick and you're laying in bed, you don't really have a whole lot of blood flow. So you may have seen the signs that we put up asking patients to box, 10 times, 30 seconds every hour. Boxing, kicking their legs, whatever they can do to make their heart pump a little bit faster and encourage blood flow. Get them up and walk. Make sure they have a PT-OT consult because we need to get blood flowing throughout their body and just not in their belly so that we can shunt more blood to the wound and get it to heal faster. Finally, and to end it, are all ulcers pressure ulcers? The answer is no. And make sure as you're looking at wounds, you're thinking about all of that and you don't stage a non-pressure ulcer. There's all sorts of other things, traumas and skin tears and arterial and venous and diabetic, and you just want to make sure you know what the difference is. Again, just to summarize, pressure ulcers are over bony prominences, and you shouldn't stage anything else besides a pressure ulcer. So the only thing I had left to show you was a couple of products that I hope to have here today, but I don't. Things that are going to be available for you. They're going to be stocked on all of the par parts to use with patients with pressure ulcers. This is a Prevlon heel boot. Who's seen them? We're going to standardize to these instead of pillows or instead of the foam ones. They just work better. Could I have somebody to show how to put this on?
I've never put one on.
Huh?
I've never put one on.
Can I put one on you?
Sure. Just my foot.
Yeah, do you mind just hopping up on the table?
Sure.
Yeah, please. You don't have to take your sock off. So the first thing you want to do when you put this on, and you'll get more in-services as we have them, but you want to flip it inside out. This stuff, and I'll pass it around, is anti-slip. So the whole point of it is to make sure you get the foot positioned exactly right, and once you flip it back up, it's not going to be slipping and slopping around and creating pressure. So you got to get it put on the first time. So how you do it is you take it and you put the heel right in the hole, hold the heel, and then you fold the rest of it up around the leg. And then it's, you follow the white to white, black to black. And in that, then you make sure the heel's floated, and it is, and you don't have pressure. So you don't want to ever put it on by just going like that because you can't get it deep enough in there. So you always got to fold it inside out and then put it on.
Can I punch a kick now?
Yeah. You can be combative patient. So I'll pass those around. And then the last thing I don't have an example of, but it's the turn position unit. The guy was here and he did an in-service for 2 or 3 days and gave us some trials. Has anybody in the room seen them? Used them? I think Melissa did, right? No? Yeah? Yeah. So this is just kind of eliminates the guesswork and understand some of the challenge in positioning a person on their side. If you have a 400 or 300 pound comatose patient, it takes several people to move them, to scoot them over to the side, to pull them over, and then try to stuff pillows underneath them, and the pillows either flatten out or they squirt out of the way, and it ends up being an ineffective transfer. And then you really should be doing it every 2 hours, but shoot, it took 3 staff members to do it, and you're really busy, and so are you getting to it every 3 hours? Probably not. The whole point of this unit is it eliminates all of the guesswork. The wedges are 30 degrees, so when you have them placed correctly, they always float the sacrum, so you know you don't have pressure on the sacrum. You know you don't have them over their shoulders or their trochs, because it's always set at 30 degrees. But instead of, you put the first time you'll need help, because you got to position the sheet underneath the patient. And then you get the sheet underneath them. It has that same gray microfiber stuff that doesn't slip, so it prevents your patient from slipping around in bed if they're going to kind of stay put. It straps to the bed, so it doesn't move. So you get your patient on it, that's the hardest part. Then what you do is you position the wedges, you fold the sheet up over the top of the patient because they're laying on their back. You put the wedges where you want them. You put the sheet back over. These 2 fingers can then pull a 300-pound patient over onto the wedge. It's that non-friction thing. So you don't need 3 people to do it anymore. You don't have to stress that in 2 hours you're going to have to find a whole team of people and hurt yourself doing it, because when it's time to change them, you flip the sheet off, you pull the wedges out, you go around to the other side, and you take 2 fingers and you slide them right over. So it really is the easiest thing in the world to use. They are a single patient use item, so you can't be using them from patient to patient. The piece of paper I sent around is for the unit that's for 350 pounds. We will order some for bariatric patients that go up to 550 as well. So we'll have a few of each stocked. And again, once we hard roll them all out, we'll make sure that we hit the floors and in-service everybody so that they're aware of them, they know how to use them, they know where to get them, et cetera, et cetera. So I'm done.
Can we give her a hand? Thanks, Holly. That was awesome.
Anybody have any questions or anything that I didn't talk about that you'd like to talk about? All right. So who's going to give the presentation next year? Robin. All right. She's not here to defend herself, so sounds good to me.